Well, hello everybody. It's 12:30. We should start with our webinar of today of the European Forum for Primary Care. In a series of webinars in 2023 about socioeconomic deprivation and health and the role of community-oriented primary care. And in that series, we have asked Erik Bischoff, who is a GP in Nijmegen, Radboud University, and research leader on chronic disease and multimorbidity, to present something on person-centered and integrated chronic care and what has been learned in Holland and what are the plans for the future. And the European Forum for Primary Care, I'm the coordinator of the European Forum for Primary Care. We are very happy with this because it's an important topic which we want to learn from, and not only from Erik, of course, because Erik presents the Dutch situation, and we are very eager to learn also from you, participants from all over Europe, even all over the world. So please join us in this interactive webinar, making sure that your experiences will be shared as well. And if you have questions, please do not wait till the end, but ask in the chat box, and we will address them. And Erik will try to respond. And if others want to interfere, it's also very much welcome. So, having said that, Erik, the floor is yours, and you can start sharing your screen. I will stop sharing my screen, which was also not a very success. I hope yours is now going well. Yeah, there it is. So, floor is yours.
Well, thank you very much, Diederik. Thank you for the invitation, and also thanks for the invitation. Thanks to the European Forum for Primary Care for the invitation. And thanks to all of you for joining this webinar. And I agree with you, Diederik. Person-centered and integrated care is a very important topic, and in my opinion, it could be very supportive in overcoming the major challenges that we're facing right now in our health system, and particularly in primary care, I believe. And I think the challenges that we're facing in the Netherlands could be very much the same as in other health systems worldwide. So my name is Erik Bischoff. I'm a general practitioner in Nijmegen, and I'm leading the research group on chronic diseases and multimorbidity at the Radboud University Medical Center. Let's hope that this will be a very interactive webinar. Please interrupt me if there are some unclarities on my slides, or if you have any comments or questions. You can ask me anytime. Before I start, I would like to show you my disclosures, and in particular, I would like to pay some attention to the funding sources for the projects that I will present during this webinar: the Dutch Organization for Health Research and Development, the health insurers VGZ and CZ, the University of Applied Sciences, Arnhem Nijmegen, and Boehringer Ingelheim. So, I'm going to talk with you about the challenges that we're facing and how, in my opinion, the current organization of chronic disease management in primary care is not able to help us solving these major challenges, and why we need a transformation of chronic care, transformation towards more person-centered and integrated care. And I will show you some front-runner projects to show you how we're at this moment are working on this transformation. And perhaps from your side, there are also some interesting topics or comments that you would like to bring in this webinar. So let's start with the challenges. I think we're facing two major challenges, and obviously the biggest one is the fact that we're facing more and more people in the Netherlands. At this moment, we have 17.5 million people living in the Netherlands, and we're growing fast. Predictions are that in 2050, we're facing 20 million people, and not only more people, but also more older people, and more older people with more chronic diseases. So it's obvious that all these people need medical care. So we need more doctors, more nurses, more healthcare professionals. But the second major challenge is that we are having a shortage of those professionals. And the predictions are that within the next 10 years, we are facing a shortage of more than 100,000 professionals. Also in primary care, and I think one of the biggest reasons is that a lot of young people are hesitating to become a healthcare professional because of the high workload, the high administrative burden. A lot of professionals are facing burnout. So it is not easy to overcome this shortage if we are needing so much people. I think these challenges are for the whole health system in the Netherlands, but particularly for primary care. And to understand this, it's good to know that besides primary care, we have secondary and tertiary care. We have care before the primary care, which is informal care, care provided by family and relatives and friends. But the biggest part of our health system is because of the primary care. More than 19% of the patients that we have in our health system are treated or managed in primary care. And within primary care, the general practitioner, the family physician, is the most important discipline, because in the Netherlands, the general practitioner is needed to refer for a referral to other disciplines within primary care, but also for referring to secondary and tertiary care. So the general practitioner is very important and the main responsible discipline for providing high quality care at very low costs. It's interesting to notice that from the total budget of healthcare costs, only a fraction is going to the general practitioner, 3.5 billion of the 50 million in total. And of all the patients that we see, so we see a lot of patients, also a lot of chronic patients, it's also good to realize that only a minority of patients contributes to this high workload that we experience as general practitioners. And these are the patients who have chronic conditions, multiple chronic conditions, and can be very complex. This is a figure to illustrate the number of chronic patients that we have in the Netherlands. It's the situation of 2021. And as you can see that with the rising age, more people have one or more chronic conditions. And if you look at the age of 75 or 75 and above, 90% and higher of our patients have one or more chronic conditions. And when you look at the situation of multimorbidity, then you can see that at the age of 75 and above, more than 75% of the patients have more chronic conditions. And by far the majority of those patients are managed in primary care and are managed by the general practitioner. So I hope that you understand that the workload caused by people with chronic diseases is mainly on the family physician, on the general practitioner. So let's have some questions for you, because I told you about the two major challenges, the challenges that we are facing, many more people with chronic conditions, complex chronic conditions, and that this is causing a huge workload, particularly for primary care and for the general practitioner. Do you recognize these challenges in your country, and how does this involve primary care in your country? And I would very like to know your answers to this question.
Anybody intrigued by this question? From Belgium maybe, or Spain or Italy, the region of Liguria is present. I saw Adriana Brusa already early registering. Do you have an opinion about this in Italy, in Liguria?
Non posso.
Yeah. Are you trying to connect?
Yes. Oh,
And maybe from Chandan from the OECD, do you have an idea about these challenges in the different countries of Europe? What are those?
I think many European countries can relate to that. And indeed, when it comes to Europe, especially, it's on primary care professionals' shoulders to take care of those with chronic conditions. So yes, I can talk on behalf of the OECD countries, but many other European countries as well who are not presented in our organization.
Yeah. Okay, thanks. Adriana, I think your microphone is now on. Can you give a short note about Italy?
Yes, the only thing is in Italy, population is decreasing, although older people are increasing, of course, in Italy as well. And there is a shortage, of course, of medicine and in particular of GPs. I would say that in Italy, it's true. All people have to go through the GPs to have a higher level of medicine, but so especially in this moment where there is a shortage of we don't have many appointments in the hospitals. Most of the people, a lot of people try to go privately to avoid the queue in the hospital with the clicks. So a lot of people bypass the GPs because going privately they do not have to have prescription by the GPs.
And to your opinion, and then I give the floor back to Erik, is that a positive development or is it a negative development?
At the moment, we don't see the light, let's say, to go through this moment. But we are working to try to the public system and try to avoid whatever is not useful. For example, we have a lot of defensive prescription, so maybe a lot of the queues are a lot of these things maybe due to this or a more necessary knowledge on some subjects to avoid useless prescription.
Yeah, thanks. Yeah, it reduces, of course, the pressure on primary care, but it challenges the equity in the system, I think. Erik, the floor is yours.
Yeah, thank you. It's very interesting what you mentioned, because I think that it is perhaps reducing the pressure on primary care, but it is replacing the pressure on the hospitals or other places, other settings. And I think a strong primary care can help us to overcome these challenges. And I agree with you that the shortage of general practitioners, we're also facing this. But in the Netherlands, the GP has a very important role, and it is really disturbing to see that we have a shortage. And I discussed with you, I talked with you about chronic care, patients with chronic diseases, and it's important to know how at this moment we have organized chronic disease management. And on the next slides, I will show you how we have organized this. So there's a map of the Netherlands, and within the Netherlands we have around 110 regions in which primary care is highly organized within primary care groups. So every region has a primary care group, and then within the group, the general practices that are in that region collaborate with each other and are connected to the primary care organization. And the role of the primary care organization is to monitor the quality of the chronic disease management that is provided, to negotiate the payment of the chronic care management with the health insurer, and the three the three images that you see here are of the major national organizations that are involved in this chronic disease management. So in AIM is the branch organization of all the regional care groups, and de Landelijke Huisartsenvereniging and the NHG are the professional associations, and those three are responsible for the chronic disease management in the Netherlands. But it is interesting to see that although this chronic disease management is highly organized, it is only highly organized for the three most important chronic diseases: diabetes, cardiovascular disease, and respiratory diseases, which all have a lot of people suffering from those diseases, more than 1 million. But on the other hand, there are also other chronic diseases with high prevalences, for which we have no organization of chronic disease management. Arthrosis, thyroid gland, gout, and I can mention many more chronic diseases. So for a couple of those, diabetes, cardiovascular, COPD, asthma, we have a highly organized chronic disease management program, but for the other diseases, we don't. And although those are also chronic diseases with high impact on people, but also on the general practice. So this slide, it shows a flow chart of how it is organized within the practice. And as you can see on the top of the flow chart, there is the care group responsible in a region for the organization of chronic disease management, and all the general practices are connected to the care group. And within a general practice, the chronic disease management is delegated to special trained nurses, practice nurses, who all provide care to a single disease, single chronic disease. So they provide care to people with diabetes, with COPD, with asthma, cardiovascular disease. So it is very single disease oriented. And within a single disease management program, the nurse can refer to other disciplines within primary care, to a dietitian, to the physiotherapist, etc. But when you look at this, and this organization is here in the Netherlands, I think since the last 15 years, it is highly organized, but it is single disease minded, which means that there's only attention for people with diabetes within the chronic disease management program, not for other comorbidities like arthrosis or gout or etc., not for other health problems. So only focused on the disease. And it is very protocolized, which is good. The quality of care is very high because it is uniform, it's protocolized, but it's not tailored to the needs of the individual patient. It's also very pharmaceutical driven. We prescribe a lot of drugs for diabetes, COPD, asthma, cardiovascular diseases, but there is not so much attention for lifestyle or other non-pharmaceutical therapies. And although a lot of disciplines work within primary care with people with chronic diseases, there is not so much collaboration. So it's multi-professional, but not interprofessional. The financing is based on perverse financial incentives. There is bundled payment per person, and most of the money goes to the general practitioner. And the more patients the GP includes in a chronic disease management program, the more money the GP gets. And I think this whole model hinders equity and accessibility, particularly for those people who are most vulnerable, people with low health education, health literacy, people from different cultures. And this model, this organization is creating undertreatment and overtreatment. Undertreatment for those with complex care needs, and overtreatment for those people who are very stable and have little other problems. So this organization is here in the Netherlands for the last 15 to 20 years. High quality of care, but a lot of negative points, in my opinion. So with this organization, we're not able to overcome the challenges that I've discussed earlier, the challenges of more people with chronic diseases, more people with complex chronic diseases due to multimorbidity. So we have to transform, we have to change. And I think there are a couple of reports published during the last couple of years in the Netherlands that could help us to solve the problems. And they're all about appropriate care. And the last report, the Integral Care Agreement, the report that was published last year, is from the Ministry of Health, Welfare and Sport, with all the important and relevant healthcare organizations, in which the tasks and the roles of every organization is agreed on to help us with providing appropriate care, to help us with overcoming the challenges and make our health system more sustainable. And there are 4 principles for appropriate care. It should be value-driven. There should be evidence that it's effective with a limited use of funding, personal resources. Should be together with the patient. It's about shared decision-making, person-centered. It's right care in the right place and close to the patient. And it's about health instead of illness. And the image that you can see here, it's I think you recognize it. The image from Positive Health, the spider web of positive health. I think last year in May there was a webinar about positive health. And you see that the concept, the movement of positive health, it was initiated in the Netherlands by Machteld Huber, has taken a very has grown very big in the Netherlands. So it's not about illness, but it's about health, appropriate care. So 2 questions for you. I'm very curious to know about how chronic disease management is in your country organized in primary care, and if so, if it is the same as in the Netherlands, do you recognize these limitations that I just showed to you? Who wants to react? Who wants to respond?
May I just first start with challenging David Smekers of Ineen. If you recognize the picture of Erik, David, could you give a small reaction, or you have something to add on this picture?
Hello, David.
Hi. No, and I also talked to Erik about it earlier, and I definitely recognize what Erik showed, and we're also considering like what do we need to change, how we can keep the good things about what Erik also mentioned, but also change also because the prevalence of chronic diseases is gonna they're gonna be way more chronic diseases to be expected.
Yeah. Okay. Thanks for the confirmation. Anybody who wants to react? Maybe from Spain, we have 2 representatives on the group. One from the Ministry of Health, Angelica Bonilla. Would you like to respond on this? Don't be shy. Or otherwise from Germany, I saw something from Bavaria, who's very into e-health. But if the management of chronic diseases is being organized in primary care.
I'm sorry, I just joined. So, but what we have in Germany is this disease management programs in primary care, the DMPs, and so people are joining this if they have a chronic disease and are looked at regularly, like every 3 months, if it's diabetes or asthma. So I'm not entirely sure how well this is working. But people are being seen by the doctor. They fill out all these forms and try to do some prevention there as well. So that's
Okay.
so much from my side.
Yeah, thanks.
Comparable with the Dutch situation, I guess. but only for a couple of chronic diseases. You mentioned diabetes.
Yeah. Okay, any other country? Alex Fontanals, also from Spain, or Delphine Caron from France? Could you add some of your experiences if disease management, chronic disease management, is primary care organized or is it differently organized? Yes, go ahead. Floor is yours, Alex.
Yeah, wait, do you listen to me fine?
Yes, go ahead.
Okay. So here in Spain, like primary care used to be like really, nurses used to have like a lot of empowerment. So they try to manage like all types of chronic disease. So we don't have like any type of specialization. They have like some nurse references. For example, in each primary care center, there is like the experience set in diabetes, experience set in hypertension, and that used to go to conferences and used to be more advanced about knowledge. But during the day and all the visits, and for example, all nurses take care of all chronic disease. So there's no specialization.
No. And the limitations, as Erik was presenting here, but for example, there is multi-professional input, but the interprofessional care is not well developed. The real collaboration between those different professions in primary care lacks. Is that still a problem?
Do you mean in Spain, Erik? Or?
Yes, in Spain. But I give the floor also to anybody else.
I guess that no in Spain, because as I said, they beginning about prescription, about pharmacs, for example, and they, as I said, they have a lot of empowerment here in Spain. So every time the nurses used to need a little more extra help from the GP, it's quite easy communication. They used to work in couples, like each nurse and each doctor, or 2 or 3 nurses for each doctor. So it used to be easy in Spain by this side.
Okay.
So because there is collaboration within the practice, but also outside the practice with other disciplines?
Yeah, like there used to be like a lot of team groups, like with physiotherapy, doctors, nurses, that they even with social parts about social workers, that they used to meet to try to work about some type of specific patients, cases, situations outside from the visit hours, to say it in a way. And then when you're visiting a patient, it's really easy to work. Like you can order 2 visits at the same time and you can make the visit together, doctor and nurse, for example.
Yeah, interesting. Well, we have a similar kind of experience with, for example, the CASAP health center in Castelldefels, where we visited again on our last conference, and it's a wonderful example of good collaboration between different professionals. Chandan, you want to react?
Yeah, I thought that maybe I could share the French example because I'm very much involved in the chronic care management in here as well. Here, general practitioner has the coordinator role, and the management of chronic diseases are like done by several professionals. Nurses have a special place in this, what we call AZELI nurses. So these are specialized nurses who provide prevention and promotion, healthcare prevention and promotion services to people living with chronic conditions. And more, we also have advanced practice nurses who are taking more advanced roles in management of chronic conditions, but it's still very much central and organized around general practitioner. You might have like physiotherapists, podologists, but these are all linked to general practitioner again, very much in a coordinating role. More and more, we see multi-professional practices, what we call it MSP, and but these are still minority in the country because several GPs have like a single-handed practices and they practice alone. One good example of collaboration across professionals is around what we call therapeutic patient education. So basically self-management programs where several healthcare professionals from primary care collaborate with each other for the care of a patient and for the education of patient. And I think this is a very good example of collaboration, but I can also relate to many limitations that you are providing. And I think here one of the things, an additional limitation, so in Netherlands, it's very much centralized. So you have national guidelines and then in the regions, like it's almost translated in the same way. But I think in France, it's very much focused on the voluntary role. So professionals can regroup themselves and build multi-professional practices, but this is not mandatory. And that's why I think there are some differences between regions and also within regions as well.
But then there is also a lot of variety in quality of care, I guess. Is it correct?
Well, I think I cannot say anything in advance about this, but now we are doing a work on quality of primary care as the OECD, and France will be one of the countries, as well as the Netherlands, who will be joining this research. So hopefully in a few months, I'll be able to say something about these differences in terms of quality of care.
Chandan is working for the OECD. They cannot say something bad about a certain country. No, that's funny. But Erik, how to overcome these limitations in the Dutch chronic disease management programs? Do you have solutions? Do you have ideas?
I have suggestions, Diederik.
Okay, go ahead.
So I'm now going to talk about person-centered and integrated care. It took some time to come to this point, but it is very important to understand how we're organized in the Netherlands, to understand why person-centered care can help us. Yes, and on this slide, I just copied the text of the WHO website. Please take a minute to read it, because I couldn't have said this better than what was written down by the WHO on person-centered and integrated care. And I think when you look at person-centered and integrated care, it's about equity, quality, responsiveness and participation, efficiency and resilience. And when you read the introduction above these highlighted points, then you see that, and I think this is particularly in the Netherlands the case, healthcare, although healthcare seems to be accessible, it is very fragmented. Fragmented in primary care, secondary, tertiary care, within primary care. And I think with person-centered and integrated care, person-centered, tailored to the needs of the individual patient, from the total context of the patient, and integrated in a way that care is coordinated and in which all the disciplines work and collaborate with each other, could help us overcoming the challenges. And when you look at the definition or the description of the WHO, and when you lay that down on all the limitations that I showed to you on the previous slide, then when we are moving towards a more person-centered and integrated way of organizing chronic disease management, then it's focused on the individual person in total instead of the single disease. So we're not focusing on only the disease, but on the person and on health in the total context, on not only diabetes, but also on the other comorbidities, on the problems that patients may experience, and the needs that patients may have. And it's more about preventive medicine and lifestyle advice instead of the reflexive prescribing medication and drugs. And it may stimulate interprofessional collaboration instead of multidiscipline working in primary care. And I think also the payment has to change, perhaps towards a more population payment for population management instead of a bundled payment for an individual patient. perhaps with more perverse incentives. And it may help us removing barriers to equity and accessibility, because it also takes into account that patients may have difficulties with health skills or reading, or it takes into account that people may be different, instead of providing the same uniform protocolized healthcare to everyone. So in my opinion, I completely agree with the WHO that this could help us in overcoming the challenges due to the people with a lot of chronic diseases and complex care needs. But how are we going to implement this? How are we going to integrate this in chronic disease management? I'm going to show you a couple of front-runner projects. And at this moment in the Netherlands, I think there are 4 major projects that are initiated by care groups, regional care groups, in close collaboration with research institutes. So we have the Target study, it's the Maastricht University, co-pilot study, the Amsterdam University, and Optima Forma and EMBOS, both from the Radboud UMC. And these research projects, these development and implementation studies, they all focus on changing single disease, chronic disease management into a more person-centered integrated care model. You can read the publications of the Target study and the co-pilot study. You can read it. It's open access on PubMed. Rowan Smeets wrote and colleagues wrote the development of the Target study, the Target model, and Mieke Boger and colleagues wrote a nice publication on the pilot study. But I want to zoom in to show you more details about the Optima Forma and EMBOS study, because those are the studies from the research group in my department, the Radboud UMC. So what we did in this study was we did not, as a research institute, did not initiate the study by ourselves, but this was initiated by regional care groups. And I think during the last couple of years, a lot of care groups in the Netherlands are struggling with this transformation, are willing to change toward a more person-centered and integrated care model, but are not knowing how to start. So a couple of those care groups, they contacted us, the Radboud UMC, and asked for help. And we, together with the University of Applied Sciences in Arnhem, Nijmegen, the Erasmus University in Rotterdam, and with VAROS, we made these two projects, Optima Forma and EMBOS, and get some funding from this, from the funding organizations that are presented on the first slide and the disclosure slide. And from the start, we also collaborated with the insurers, the health insurers. And these 3 are among the largest health insurers in the Netherlands, and also responsible for the payments in the regional care groups that participated in these 2 projects. So what we did, how we started, was to start with the literature. We scanned the literature, we scanned all the guidelines, just to see how person-centered and integrated care for patients with chronic diseases, patients with multimorbidity, could look like. And based on the literature review, we developed a model, and the model is more like a multi-dimensional model to take into account all the problems and all the needs that patients could have. So it does not focus on symptoms or physiological functioning related to one single disease, but it's about all the symptoms patients can have, the physiological functioning, but also on functional disabilities, quality of life, and social functioning from the total perspective of the patient. It's a broad assessment with which you start when you start with chronic care. So it doesn't matter if a patient has diabetes or cardiovascular disease, or a patient has one chronic disease or multiple chronic diseases. It's a broad assessment of all the most of all the domains, the most important domains that people can experience health problems. So this model was developed based on literature, but then we asked the opinions of the professionals. So every region that participated made a group of professionals, and they all provided feedback to this model. And it was a broad group, and not only GPs or nurses, but also physiotherapists, dietitians, etc., etc. And after the feedback, we also asked patients about their opinions. So we interviewed a lot of patients, and with their feedback, we used them to further optimize the model. And at the end, we asked the feedback from the most important national stakeholders or regional stakeholders, so the policy advisors of the primary care corporation, care groups, or the policy advisors of the healthcare insurers. So with all the input, we finalized the model that was built based on the literature, and with this model, we also, so this is a broad assessment, we also made a patient journey, which is displayed here, how to use the model. And the idea was to let patients at home prepare the consultation and think about the problems they may have and the needs they may have. So it starts with, of course, with the preparation at home. It could be a digital preparation, so a digital questionnaire that could be sent, could also be on paper. And by doing this, the patient is better prepared when the patient visits the nurse or the doctor. And during the consultation, the discussion is about the problems the patient may have on one or more domains, depends on what the patient wants, and the needs that the patient have. And based on that, goals can be formulated, so personalized goals. The goals are written down in an action plan, an individualized care plan, and with that plan, patients can go home, can start with actions to reach the goals. They can do it on their own, if possible, or with the support of the general practice, the nurse, the practitioner, or with the support of other disciplines. And after a couple of months, the patient come back and the goals are evaluated. But it's not only the model or the patient journey, so the process in which the model is implemented, but it's about more. It's also about the financing of this model. So what is appropriate financing? Because we had some doubts if the current way of financing chronic disease management would also suit this model. So we did a study on that, published. I hope, Diederik, that the slides can be shared. Is it possible with everyone? Is it?
Yeah, it can be shared. The whole webinar will be on our YouTube channel a couple of days after we have closed the webinar, so you can see all the slides through this video.
You can also see the references and read the literature. It's very interesting. I think I don't have time enough to explain more about these publications, but please read it. But the important thing I would like to mention is that financing is a very important precondition for success. Also, the competences that the professionals need, because we're changing the way they have worked for so long, 15 to 20 years. And now we are saying that they have to provide personalized and integrated care, which may be different from the highly protocolized care that they have delivered so far. So you could expect that they need other competences that they already have. Competences about person-centered care, about integrated care, but also about interprofessional collaboration. And we also did a study on that one, also published this year, a scoping review. So based on the literature, what kind of competencies do professionals need? And the third one is digital support. Digital support how to write down the individualized care plan, how to share it with other disciplines, with the patient, how to communicate with other disciplines in order to improve collaboration. So in our opinion, these three are very important preconditions that should be met before you start with implementation of the personalized and integrated care model. So after we have thought about these things, developed these things, we started with pilot testing. And we started pilot testing with 7 practices in 3 regions in the Netherlands, and we followed the patients for 6 months. And at the end, almost 100 patients participated, patients with diabetes, with COPD, with cardiovascular diseases, or with both or all 3 of these diseases. And we followed the process of the implementation. We measured PROMs and PREMs. We did not measure those PROMs and PREMs to measure efficacy, but just to see how feasible it was to use these questionnaires. And after 6 months, we also had interviews with the patients and professionals. So of those almost 100 patients, the majority was female. Half of them was above the age of 65. And also very important, a lot of them was low educated. Almost 1 in 3 had low education, and 1 in 5 patients needed help reading medical leaflets. So this, in my opinion, a very large part of these people can be very vulnerable. And almost 40% retired, so almost 60% was working, had a job, so was also dealing with chronic diseases and work and labor. All right, so the process evaluation that we held, that was revealed that at the end, almost 80% of them had an individual care plan, had goals formulated, but only 18% of them was referred to other disciplines, to the medical specialist, to the physiotherapist, etc. Only 3% of them was referred to social work. So it surprised us that although a lot of those patients had formulated goals in an individual care plan, by far the majority of them didn't need any help. It seemed that they didn't need any help from other disciplines than from the general practice. So either the general practice supported them or they did it by themselves. The number of contacts that I had during those 6 months was 2 median, and the duration of contacts was 45 minutes with a range of 10 to 75 minutes, which was quite long, longer than the time they had before in their chronic disease management programs, which was about 20 minutes, 30 minutes. The qualitative interviews revealed that patients actually were very happy with this new approach. There was more attention for them as a person. So it was not only about the disease, but about them as an individual. And by having this kind of discussions and formulating these goals tailored to what they needed, they were also more motivated to work on their health. On the other hand, the professionals stated that they had better insight in the total context of the patient, experienced more depth and a better contact with the patient. But they also mentioned that they needed more education than what they had before they started with the pilot. I forgot to mention that all the practices that started with the pilot were educated in using positive health. So they were trained in providing positive health with the spider web to the patient, but it was just one training. So they needed more training, more education. They needed supervision. And they also needed more education about how to collaborate with each other, because they experienced that although the patients had a lot of problems, they didn't know how to support them with other disciplines than themselves. So they thought they had to help the patients to do it all by themselves, which was also an explanation why the consultation times took so long, 45 minutes to 70 minutes sometimes, because they had in their mind that they had to solve all those problems by themselves instead of referring the patients for support from other disciplines, which sometimes could be better. And the low educated people also said that the tools that were provided with the positive health, the questionnaire, but also the conversation with the spider web and the domains and the figures that you have to give in every domain could be very difficult. So our next step was based on the feedback from the qualitative interviews and based on the process evaluation to optimize the intervention. And what we did was two things. We developed in close collaboration with Pharos tools and a training, particularly on low educated people. So we developed this talking board with images with all kinds of health problems that are specific for those people with low health literacy, low education. So we developed it in co-creation with these people. And we also developed a training on interprofessional collaboration for the healthcare professional. So now we are in the middle of a cluster randomized controlled trial. We started it half a year ago with more than 40 general practitioners, and we followed them for 12 months. We have included more than 1,000 patients. 520 patients will receive person-centered and integrated care, of whom 400 patients using the tools of the positive health. But we also included more than 100 low-educated patients who would use the tools that were developed by Pharos. And we compare those patients after 1 year with 520 patients who continue with care as usual, so continue with the protocolized single disease, chronic disease management programs. And after 12 months, we also we were going to collect quantitative and qualitative information. So we are going to evaluate the process. We measure PROMs and PREMs, the costs. We also measure experiences, and we also will do interviews with patients and professionals. We expect that halfway next year, we will finish the follow-up, and then at the end of next year, we can publish the first results. I think I'm at the end of my presentation, and I'm not able to give you some first results of the trial yet, but based on the experiences so far, I think we as a group have two important insights. And I think the first insight is that changes in healthcare systems can only be forced through appropriate financial incentives. And what I mean with this is that what we noticed so far is that the practices that participate, we did not change the way of payment for them. Although we have some ideas, we've published it, the regions and the health insurer were still very conservative and continued with the way they financed chronic diseases before. And it's very single disease funded, very single disease payment. So it's difficult, I think, for the practices to completely change their way of providing care if they still have to fulfill the things that were agreed on in the previous way of financing. And the other thing is that we noticed that it's difficult for the nurses to change the way they have worked for so long. So they have worked for so long using strict protocols, focusing on a single disease. And now, although we have trained them, although we continue the training, it is not one-time training, it is continuing, it is with intervision meetings, they find it very difficult to change the way of working. And perhaps we need a new generation that is educated, not in the way the current generation of practice nurses is educated, so not single diseases, but educated on person-centered integrated care, before we can truly see that the changes have been made. Okay, so
Thank you, Erik.
This was my presentation. Special thanks to my research group, and also special thanks again for the EFPC for inviting me.
Yeah, thank you. Well, this brings to me a lot of questions and things to discuss. There are some questions in the chat box, but my first question would be especially to Maxence Prize from International Diabetes Federation. I hope you are still there. I think first question to you: do you confirm that like Erik is saying, a single disease should not be approached only on this single disease, diabetes, but should comprise the whole different multimorbidity? And if so, would the IDF, looking at the last slide of Erik, be able to propose more diverse financial constructions instead of the single disease construction? Maxence, are you still there?
Yes, I am. Do you hear me?
Yeah, good.
Okay, so nice to meet you. Just to notice you that I am a new intern, so I just joined IDF, so I might not be able to respond to your second question because it might be a little technical for me. But for the first question, at IDF Europe, we totally agree that the single approach disease is not the right one because, for example, on diabetes, diabetes is the root cause of many other communicable disease. So we profoundly advocate for a multidisciplinary approach and a comprehensive approach of non-communicable disease. So this is something that we are really into, and for my side as an advocacy and policy trainee, this is something I really try to work with the European Parliament.
Okay, sounds good. And I can imagine that it's hard to say something about the policy and try to change the system. But I think if you read Erik, if you listen to Erik very clearly, there is a role to play, I think, because if all the single disease organizations still only lobby for their own sake, to put it a little bit bluntly, we will not reach that level which Erik proposes. There is a question of Thor from Norway about shouldn't it be from person-centered to community-oriented, community-centered, and then I think he thinks about a community diagnosis, that for in a certain quarter of a city there is a typical collection of diseases where you should provide different care than in other parts of the town. Would that make sense, Erik?
Well, I can imagine that it can make sense depending on the area and the city, because not every city, not every community is the same, and I think this model is appropriate for every situation because it's not focused on the disease; it's focused on the human being, on the person.
Yeah. Okay. Maybe Harry, because you also had some questions about this question. The floor is yours, and then I will give it to another person who raised his hand. Harry first.
Hi, yeah, Harry Longman. I'm not a healthcare professional. I have worked with GPs really in IT system and accessibility, but now my main job is I'm a carer for my mother, who is 92, and she has 12 different prescription meds every day and some others occasionally. So now I relate to the system in a very different way. And so I love, data analytics and so on, but this is now I have one huge data point. Absolutely, a disease focus would be completely useless. This is all about the person. And there's one phrase I would change in the WHO definition, which I love, by the way. And the one phrase it says allows for patient participation in their health needs. Yeah, that should be encourages. Yeah, encourages, or you could even say strongly encourages. My mother is very highly educated, and on good times she's strong, but actually accessibility is so important, because things happen any day, all the time. I have care notes, yeah, and all the medications. I make changes every week, sometimes every day. Yeah, we've had very good help from a specialist in the hospital about the bronchiectasis, but there's lots of other stuff as well. So I would say absolutely it needs to be person-centered, very individual, and encourage the patient and carers to understand what's going on, because even one little thing which seems quite small, if it doesn't happen right, the patient goes down, and then you have much higher costs, pain, suffering. So lots of little things all the time you think, oh, that's expensive. No, it's not. No, it's very low cost, because not going right is super high cost. So thank you.
Yeah. Thank you, Harry, for confirming, I think, what Erik is stating. We are a bit over time, but I have one more request to respond. Pavlos Beska, can you take the floor? I don't hear you, but your microphone is unmuted, so that should go well. And maybe something on your microphone is not completely well installed. Okay, well, try to fix it, because in the meantime I'm having one more question in the chat box, and that was more on a way that from Francesco Pistolato, I think from Italy, shouldn't be prevention activities for chronic diseases starting in much earlier years of somebody. So in fact at school level, that and that it should be much more financing these kind of prevention activities rather than, well, later on at later age.
Is that a question for me, Diederik?
Yeah, that's a question for you. All the questions were for you.
It's a very good suggestion, and I think this webinar was about chronic diseases, how person-centered integrated care can help us in patients who have already chronic diseases. But I think the best way to have impact on this huge challenge of chronic diseases is to prevent people from getting a chronic disease. And so preventive medicine and lifestyle is very important. Help patients stop smoking, or help prevent children from starting with smoking. So that's very, very important. I agree.
Yeah. Okay, I think we have to wrap up. My last contribution is on the interprofessional collaboration. I always say it starts with interprofessional education. You confirm that, but I think it starts already at the basic level. So learning from each other's talents, and becoming each other peers. So a nurse should become a peer of a GP, of a physiotherapist, of anybody else at primary care level. So you know each other's talents, and you can refer in that way very easily. And I think that's a crucial point within many educational systems, that it's still not the case. We teach interprofessional collaboration, but it should be incorporated in the whole educational system. And I think there we need to make a lot of further steps. And I think the professional associations are playing a crucial role in this, because there is also a little bit of they are afraid that their own profession is not well taught if we go more into interprofessional collaboration. So I think there is a role to play. So that's a learning point, but also the financial issues which you mentioned is a crucial thing to take care of. And that, well, so thank you very much, Erik. for this interesting and vibrant, interactive webinar. I only want to warn you that we have another webinar next week, in 1 week from now, focusing on the young professionals. So taking, if we talk about interprofessional collaboration of the new colleagues, we will present the way of working from Kazakhstan, from Kenya, and from the UK, with GPs working in these constellations, and they want to talk about how to create more resilience of the different professions working in primary care. So you're all welcome to join this webinar in 1 week from now, on the 14th of December. Thanks a lot for joining us, and have a good afternoon. Thank you, Erik. We keep in contact about the follow-up. Bye-bye.
Bye-bye.
Thank you, Erik. Fantastic.
Thank you.
Great deal.